All right, welcome everyone. Very excited to be here today. We're going to talk about a very, very important topic. We're going to be talking about community-acquired pneumonia. And this is a really, really big thing. We see this nearly, every week that we're on service. So it's really important that we have a working understanding of how to work up community-acquired pneumonia, how to treat it, how to triage it, when do we draw blood cultures, sputum cultures, things like that. Okay, so get your pen and paper out. And we're going to kind of start from the beginning and just work our way through. Okay, so the first thing is let's do a little bit of nomenclature. Okay, so when we talk about pneumonia, there's a couple of different types of pneumonia that I want you to be aware of. So there's community-acquired pneumonia, and that's what we're going to be talking about today. There's HAP, or hospital-acquired pneumonia. We're going to save this for another talk. Okay, but this is pneumonia that occurs in a hospitalized patient over 48 hours after admission that was not brewing on admission, okay? And you may have heard in the past about a subtype called HCAP, or healthcare-associated pneumonia. Sometimes I still hear people talking about this. We want to take this and just delete it from our memory right now, okay? The updated guidelines from IDSA and American Thoracic Society have essentially said people who were previously in this HCAP or healthcare-associated pneumonia, now really epidemiological risk factors, they kind of fit along the lines of community-acquired pneumonia, okay? And so when we're talking about pneumonia, really all I want to hear about is community-acquired pneumonia or is it hospital-acquired pneumonia, okay? So, like I said, we're going to be talking mostly about community-acquired pneumonia right now, okay? So, CAP. So the first thing that we have to do is we have to define this, either severe or non-severe community-acquired pneumonia, okay? So when the patient comes in and they're diagnosed with this, I want you to be telling me, is this severe or non-severe? And the reason why this is important is because this dictates sort of the diagnostic workup that the patients get, as you'll see here in a little bit, blood cultures, sputum cultures, the MRSA nasal swab. And it also dictates our empiric treatment options, okay? So when we talk about severe community-acquired pneumonia, there's major criteria and there's minor criteria. Now, the major criteria are MV, are you mechanically ventilated from community-acquired pneumonia? Or SS, are you in septic shock? So are you on vasoactive agents? If you have either one of these, by definition, you have severe community-acquired pneumonia. That part's not hard to understand, right? But there's also minor criteria. And I don't necessarily want you to remember every single one of these. You can write these down. You can always look them up. But the point is that there are minor criteria for defining this, okay? And so I'm going to list them here for you. So one is the respiratory rate greater than 30? Is the P to F ratio under 250? Do I have altered mental status? Is the pneumonia multilobar? Do I have a BUN over 20? Do I have a white blood cell count under 4,000? Do I have a platelets under 100,000? Is my temperature under 36? And do I have a systolic blood pressure under 90? So these are our minor criteria. And if you have 3+ of these minor criteria, then by definition, you have severe community-acquired pneumonia. So most of these you can just get by the labs that the emergency department will order by a physical examination with altered mental status, looking at the vital signs, okay? Does that make sense? Is that clear? Okay. The next part I want to say, though, is that when we look at the guidelines for community-acquired pneumonia, the updated guidelines that came out at the end of 2019, they didn't really include our immune-compromised patients or our returning travelers. And so when we talk about white blood cell counts and platelets, I don't want that to be mixed up with, well, this is a chemotherapy effect. This is going to be simply from the pneumonia itself. Do you have a low platelets? Do you have a white blood cell count that's under 4,000? Okay? All right. So I know you guys got that. Very, very simple, right? So then let's talk about when do I get blood cultures? When do I get sputum cultures? When do I get urinary strep pneumo? When do I get urinary Legionella, right? So this is why it was really important that we said, is this severe community-acquired pneumonia or is this non-severe community-acquired pneumonia? Now, we're talking about hospitalized patients right now, okay? I work in a hospital. I'm a hospitalist, internal medicine physician, and so I'm not working in an outpatient. So for us, we really want to say when this patient is admitted, am I getting these, okay? So let's talk about blood cultures and sputum, gram stain, plus culture, okay? Now, fortunately, it's the same criteria for us to be getting these, okay? So if I have severe criteria, if I meet severe criteria, then I'm going to get blood cultures, makes sense, and I'm going to get a sputum gram stain and culture. Now, a lot of people will say, you know, sputum gram stain and culture, it's a waste of money. We really never find anything on that, and sometimes that's the case. So for outpatients, you know, we're not really ever going to be getting these. But we make our antibiograms too off of blood cultures, off of sputum gram stains and cultures as well. So if you make severe criteria, we really want to know the organism, both so we can narrow treatment, but also really helps everybody else out in terms of you know, antibiograms. Okay, so if you meet severe criteria, get blood cultures, get sputum gram stain and culture. Ideally, these are done before antibiotics are done, okay? The other criteria, and we're gonna hit on this too a little bit when we talk about treatment. If I'm empirically treating for MRSA or Pseudomonas, I really want to be getting blood cultures, sputum gram stain and culture. In the case of MRSA, I want to be getting my MRSA nares, my PCR of my MRSA nares, my nasal swab. And what this really is because I want to be able to narrow. If I'm empirically treating with something big and broad like vancomycin, or if I'm using Pseudomonas coverage with something like piperacillin tazobactam or cefepime, I want to be able to narrow that at 48 hours if I'm not culturing these things, okay? So empirically treating, that's we would want to get blood and sputum cultures and gram stain at that point. And if you have risk factors for MRSA or Pseudomonas, we would want to get blood cultures, sputum gram stain. In the case of MRSA, we would want to get a MRSA nasal swab as well, okay? So these would be our indications: severe community-acquired pneumonia, if I'm empirically treating for MRSA or Pseudomonas, or if I have risk factors for MRSA or Pseudomonas, I would want to be getting blood cultures, sputum gram stain and culture, okay? We'll go a little bit more into this when we talk about empiric treatment for them, but this is really, really important, okay? I'm going to say a little bit about procalcitonin right now since we're in the diagnostic portion. You know, procalcitonin has, there's a lot of big believers in it, there's a lot of non-believers in it. You know, when we talk about sensitivities of procalcitonin for really determining is this bacterial, is this viral, the studies show us that it's about 38 to 91% sensitive. That's a really, really broad range, 38 to 91% sensitive. So we really don't want to use procalcitonin for should I start antibiotics, right? If it's high, what does that mean? It really should be, does this patient look like they have bacterial pneumonia? Do they have a cough? Do they have a fever? Are they hypoxic? Do they have an infiltrate, right? Because I know that my procalcitonin can be normal or it can be negative in atypical pneumonia cases, right? And so if I have mycoplasma, am I not going to treat mycoplasma pneumonia with antibiotics? Well, sure I am. But if it's mixed viral bacterial, hello, influenza, winter season, superimposed you know, bacterial infection, the procalcitonin can be normal or low. So I don't ever want this to make my decision of either starting antibiotics or tapering them off, and we'll get to that when we talk about duration of antibiotics. So I never really order this. You might come across people who want to, but 38 to 91% sensitive. I want you guys using your brains. Does this look like pneumonia? Does this talk like pneumonia? Does this walk like pneumonia? And understand that it's very, very differing sensitivities when we talk about these, okay? All right. we're working our way through community-acquired pneumonia. We've defined it. We know when we need to get blood cultures, when we need to get sputum cultures, when we need to get a procalcitonin. Never, right? So let's now talk about imaging for community-acquired pneumonia. So everybody should have a chest x-ray, okay? We need to look for that infiltrate, right? And so your initial chest x-ray, sometimes it's done in the ED, a lot of times it's done in the ED, a lot of times it's a one view. Two views are always going to be better for picking up infiltrates, okay? So if you can, get a two view. But sometimes our chest x-rays can be negative, especially early on. So patients who are immune compromised may not be able to bud an infiltrate. People who are very elderly, people who are really volume down, we might not be able to get that infiltrate right on day one. So go ahead and if you feel like it's pneumonia, empirically treat, but I would repeat that chest x-ray the next day after these patients have received some fluids. And if not, and you still think it is, you know, CT scans are going to be your next option. Okay, this is a board question too. You know, chest x-ray, then a CT. You know, we never want to go to a bronch unless we get a CT scan first, right? Because we could be missing something that's making the patient septic, a pleural effusion, maybe it's a cavitary lesion that wasn't picked up on a chest x-ray. Fun fact, chest CT is about 7 times more radiation exposure than a chest x-ray. Sometimes you patients might want to ask that, okay? So this is our natural progression in terms of imaging that we want to do. And I always say, you know, listen, if you have pneumonia, but your patient's not responding, you've had an infiltrate, repeat the chest x-ray or go to a CT scan because you may find a pleural effusion that you need to tap, okay? All right. So we got the imaging portion done. You guys are moving right along. I do want to say one thing about what kind of scoring systems we use for admitting patients to the hospital. You know, I'm an internal medicine physician. I mentioned this, so I don't see patients right in the ED a lot of the times. But you might get this on a board exam question about should I admit this patient, should I not admit this patient? So there's a couple of scoring systems. One is the CURB 65, and the other one is the Pneumonia Severity Index. And so the Pneumonia Severity Index, it's a lot more time intensive. There's a lot of more criteria than in the CURB 65, right? CURB 65 is, you know, confusion, what's your BUN, what's your respiratory rate, what's your blood pressure, and are you 65 years old? So it's very easy. But the PSI is more validated. And so if you get a question on this on your board exams, you always want to say that the Pneumonia Severity Index is my indicator of should I admit this patient or not, right? So the higher the pneumonia severity index, the more points you have, the worse off that you're going to be. These are not as good for what level of hospital care the patient should be admitted to. We want to use the severity criteria that we went through earlier. And what does the patient look like, right? Lay eyes on the patient. So this is really for should I admit the patient or not, okay? All right. So much pneumonia, such good stuff, okay? So let's get into the good stuff, right? All this is good stuff, but let's get into the treatment, okay? And we're gonna talk about antibiotics now. And I know for internal medicine physicians, internal medicine residents, sometimes antibiotics is like this black box of, you know, what covers what, and what covers MRSA, what covers Pseudomonas, what covers atypicals, things like that. To be really good at antibiotics, and you'll hear me say this a lot in different videos, is you need to study antibiotics 3 different ways to be really, really good. One is taking an organ system, like, I don't know, pulmonary infections, and saying, okay, what are empiric antibiotics that I can use for infections here? Which ones can I not use? Then you need to study it by organism. So let me take MRSA, let me take Pseudomonas, let me take group A strep. And what are the different antibiotics that cover those organisms? And what's the difference? What's the difference between vancomycin and daptomycin and linezolid, right? When we're talking about MRSA. And then the third way is taking a antibiotic class. So this is like beta-lactams or fluoroquinolones and breaking it down into penicillins and cephalosporins and monobactams and carbapenems and what's the spectrum? What are they missing? What are the side effects? Okay, and then you start to make connections in your brain. And I'm going to show you how to do that as we move along and we make more videos, okay? But let's talk about empiric treatment now, right? Because when these patients come in, we really don't know what the organism is. And we cannot base typical organisms, things like strep pneumo, Haemophilus, or atypical, things like Mycoplasma, Legionella, based on chest x-ray, okay? It's just not sensitive enough. So if anybody ever tells you, well, the chest x-ray looks atypical, that may or may not be true. It's not like we're not gonna use the right coverage just because it looks a certain way, okay? But we do want to be covering for strep pneumo and Moraxella and Haemophilus and Legionella, Chlamydia, and Mycoplasma in our empiric regimens, okay? So I mentioned that severe and non-severe was really important to tell apart. And part of the reason, not just for diagnosis, when we get blood culture, sputum, gram staining culture, it's also for empiric treatment options, okay? So let's look at non-severe community-acquired pneumonia, right? So let's go back. They're not mechanically ventilated, they're not in septic shock, and they don't meet 3 or more minor criteria, right? This was respiratory rate, the BUN, the P to F ratio, multilobar, altered mental status, right? All of those that we talked about. So in non-severe options are this. You want to do a beta-lactam as your base, and then you can add a macrolide or doxycycline to that, or you can do monotherapy with a fluoroquinolone. Okay, so let's see what this looks like. So your beta-lactam, ceftriaxone, or you can do amsulbactam, okay, or you can do ceftaroline plus azithromycin, or if you have contraindications, board exam loves a prolonged QT interval. Board exams love a prolonged QT interval. Fluoroquinolones and macrolides will increase your QT. So if you have that, or you're on another QT prolonging medication, then you want to be going with doxycycline instead of azithromycin, adding it to your beta-lactam, okay? So ceftriaxone, or amsulbactam, or ceftaroline, plus azithromycin, or doxycycline, okay? So if I have a prolonged QT, I could do ceftriaxone plus doxycycline, or I could do amsulbactam plus doxycycline, right? A quick word about ceftaroline. And when we go through beta-lactams, I'll mention this as well. Ceftaroline is a 5th generation cephalosporin, okay? The spectrum of ceftaroline is that of ceftriaxone plus added MRSA coverage. But the Focus 1 and Focus 2 trials, which looked at ceftaroline in community-acquired pneumonia, this was non-inferior, okay? But it didn't look at MRSA pneumonia. It looked at typicals, right? It looked at strep pneumo. So just because you're using ceftaroline, I don't want you to think that that's okay, it will cover MRSA. We can't assume that because the trials didn't look at it. It was just against ceftriaxone, okay? The benefit of ceftaroline is that it retains its activity against strains of strep pneumo that are intermediate resistant or resistant to ceftriaxone. Okay, so you might be working in a hospital setting where ceftriaxone is resistant, strep pneumo is resistant to ceftriaxone. Ceftaroline could become an option at that point, okay? Ceftaroline is also FDA approved for skin and soft tissue infections. It binds to penicillin binding protein 2A, which is what is produced by the MEK-A gene, okay, and that's from MRSA. But in the setting of community-acquired pneumonia, we don't want to assume that it covers MRSA, okay? Does that make sense? All right. The other option here is, or you can do monotherapy with levofloxacin, or monotherapy with moxifloxacin. Now, we talked about how we want to make connections in our mind between different antibiotics and classes. So if I'm studying antibiotics right now, and I'm studying community-acquired pneumonia, I'm saying, well, what's the difference between levofloxacin and moxifloxacin, right? That's the way that we would want to do it. Well, we know that they're both respiratory fluoroquinolones. They have to be because we're talking about it in the setting of community-acquired pneumonia. So they both cover strep pneumo. They both do atypicals. Moxifloxacin has the least pseudomonal coverage of all of your fluoroquinolones, but it actually has better anaerobic coverage, right? So our fluoroquinolones don't really cover anaerobes. Moxifloxacin does cover your anaerobes. So that's the main difference between these. Less pseudomonas coverage, but more anaerobic coverage versus levofloxacin, okay? So, does that make sense? So I could get away with just doing monotherapy with levofloxacin if I wanted to, okay? But I will say in the hospital setting, we always want to do a beta-lactam plus a macrolide. That's going to be our first. If we have contraindications, you could do levofloxacin or moxifloxacin. We're trying to save the fluoroquinolones as much as we can. What about severe? So if I have severe community-acquired pneumonia, so I'm either mechanically ventilated, I'm in septic shock, or I meet 3+ criteria of those minor criteria that we talked about, then our treatment options are kind of the same, but there's a little bit of a difference, okay? So I still want to do a beta-lactam as my base. So ceftriaxone, or ampicillin sulbactam, or ceftaroline. And I still need to add it to something. So I can add it to azithromycin, or I add it to a respiratory fluoroquinolone, so levofloxacin or moxifloxacin. So the two differences then are, if I can, I don't want to use the doxycycline. I want to use azithromycin. And I'm not going to use monotherapy with a fluoroquinolone. I'm going to add that fluoroquinolone to my beta-lactam, okay? So ceftriaxone or ampicillin sulbactam or ceftaroline plus azithromycin. Or my second option is ceftriaxone or ampicillin sulbactam or ceftaroline plus a respiratory fluoroquinolone, levofloxacin or moxifloxacin, okay? Does that make sense? Okay. What about anaerobic coverage? What about anaerobic coverage? So let's say your patient, their wife, their daughter, their son says, you know, I saw them aspirate, I'm worried they have aspiration pneumonia, or somebody asks you about that. So we typically would say in the past, you know, well, they should be on anaerobic coverage, right? So of those options that we just listed, really sulbactam is the only one that has anaerobic coverage. We know cephalosporins have poor anaerobic coverage. We said fluoroquinolones have poor anaerobic coverage. But the guidelines that come out recently at the end of 2019 said, you know, look, all these trials, we haven't really seen anaerobes as big causes of aspiration pneumonia. And really isn't every pneumonia aspiration, right? Aren't we all, you know, breathing and coughing and all that stuff? So we would only need to add anaerobic coverage if the patient has a lung abscess or if they have an empyema. Okay, so a lung abscess or an empyema would be grounds for adding or using anaerobic coverage. Okay, so this is sulbactam. This is, you could use piperacillin tazobactam, it's very broad. You could use a carbapenem, that's also very broad. Clindamycin. You could use moxifloxacin if you're in a pinch and there's lots of antibiotic allergies. But in your regular old community-acquired pneumonia where there could be aspiration, you don't need to add that anaerobic coverage to the patient. Okay? All right. Let's talk about MRSA and Pseudomonas risk factors. Okay? So let's talk about MRSA first. So, you know, we go back to Clinical Infectious Diseases, great journal. 2016, they had this article and it, you know, looked at over 2,000 patients with community-acquired pneumonia, and it said, wow, you know, based on blood and sputum cultures, we only found MRSA, or we only found Staph aureus actually in under 2% of the patients. Okay, this is over 2,000 patients were looked at. Under 2% had Staph aureus, and under 1% had MRSA. Okay, that's not very many. But it was covered for empirically about 33% of the time. That's a lot, right? People with MRSA and people with Pseudomonas, they're really sick, right? I mean, if you have MRSA pneumonia, you're not going to be walking around and just doing fine, right? You're going to actually, most of the time, you're going to look a little bit worse. So MRSA is a very common colonizer, but it's not a common pathogen. And that's what I really want you to take away, that you have to really be pushed to start something like vancomycin or linezolid would be your second line. Okay, so vancomycin or linezolid. Why don't we use daptomycin? Anybody? Think about that? Yeah, it's inhibited by pulmonary surfactant. So I don't want anybody to be using daptomycin as an empiric treatment option for any type of pneumonia. So MRSA and Pseudomonas, the guidelines really kind of leave it up to certain hospitals. They're not as specific as I'd like it to be, but they really want us to rely on epidemiologic or local risk factors for MRSA or Pseudomonas. So if your hospital has that, that's great. Use the local risk factors as one of your grounds for starting empiric therapy on it. But there are some general principles that we can follow. So the first one is if you have isolation of MRSA or Pseudomonas in your sputum within the last 12 months, no matter if you're severe pneumonia or you're non-severe pneumonia, this would be grounds for empirically starting treatment, okay? So for MRSA, we said it was vanc, or if you had side effects, linezolid. Spelled that wrong. Vanc or linezolid, okay? Vanc is always going to be your number one. It's good, it's cheap, it works well on most people, okay? The second thing, the second one I want you to understand, it's a little bit trickier, is this. If you have been hospitalized and you've had IV antibiotics within the last 90 days. So you've been hospitalized and you've had IV antibiotics within the last 90 days. These IV antibiotics don't necessarily have to have occurred in the hospital setting. They could be as an outpatient. Then if you have non-severe pneumonia, you would get your blood cultures, you would get your sputum gram staining culture, you would get your MRSA nasal swab, but you wouldn't empirically treat unless one of those is positive. No empiric treatment unless they come back positive. So your sputum, right, you're seeing GNRs or in the sputum GPCs, right? If it's severe, you're still getting your blood cultures, your sputum gram staining culture, your MRSA nasal swab, and you're going to empirically treat. And then you'll narrow at 48 hours if these are negative, okay? So Staph aureus and Pseudomonas grow incredibly well on conventional agar, okay? So if you have one of these in your sputum, or if you are infected with one of these, you're actually going to see it grow within 48 hours because they just grow so well, so well, okay? This MRSA nasal swab, I want you to understand, is we have to look at it in terms of negative predictive value and positive predictive value. So negative predictive value. So if I'm saying this, what am I actually meaning? I mean, well, if it's negative, what is the likelihood that I don't have this infection, right? So the negative predictive value is about 98%. So if my MRSA swab is negative, I can feel really good that I don't have MRSA as my causative agent, right? And I could probably, I'm not colonized with it, I can probably just take off the vanc if I started it, especially if my gram stain is negative. My positive predictive value is somewhere around 33%, 33%. So even if this is positive, even if my MRSA nasal swab is positive, it's still more of a likelihood that I'm infected with something else than with MRSA, okay? So it's not as good for a positive predictive value. It's much, 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 much better for a negative predictive value, okay? So hospitalized and IV antibiotics within the last 90 days. If I have non-severe pneumonia, I'm getting my blood cultures, my sputum gram staining culture, my MRSA nasal swab, but I'm not empirically treating unless I'm really pushed to do so. Severe pneumonia, I'm getting my blood cultures, sputum gram staining culture, MRSA nasal swab. I'm empirically treating, and then I'm narrowing at 48 hours based on my sputum and my blood and my MRSA nasal swab, okay? And this is how I want you guys to be presenting it to your senior residents. This is how I want you to be presenting it to your attending physician. You're gonna say, this is a patient who has, non-severe pneumonia, and they have been hospitalized with IV antibiotics in the last 90 days. But because they're non-severe, I do want to get my blood and sputum or nasal swab, but I don't want to empirically start treatment yet, right? So that's kind of how you want to go in and talk about your patient during your daily rounds. Severe, the same thing. When we empirically treat, again, we said it was going to be vancomycin or it was going to be linezolid. If we're doing pseudomonal treatment, then we're adding it or we're substituting it. So instead of ceftriaxone and azithromycin, maybe we're doing cefepime, right? Or piperacillin tazobactam, okay? So those are going to be your go-to from a beta-lactam standpoint. Does that make sense? Does that make sense? Cool? Okay. What about duration of treatment? What about duration of treatment? So duration of treatment is fairly straightforward. So if somebody's improving and you've got them on the right antibiotic, you're going to treat this patient for 5 days. 5 days is the lowest amount of time that I would go for somebody to be treated for community-acquired pneumonia. You can extend that if somebody's slow to respond, maybe they're elderly, you could do 7 days. But you don't have to do these 7 or 10 or 14-day courses in your vast majority of people. 5 days is totally fine, okay? Extend it 7 days if you have MRSA or Pseudomonas, because that's what hospital-acquired pneumonia is, okay? And we'll talk about that in a later video. But 5 days is totally fine. So the question is, do we need to get procalcitonin then, right? We kind of hit on that a little bit earlier. The studies that looked at procalcitonin for community-acquired pneumonia looked at studies way longer than that 5-day recommended course, that 7-day recommended course. I'm not going to treat somebody for 3 days for community-acquired pneumonia if my procalcitonin, went to normal. Okay, so if I'm using my 5-day course, then there's really no reason that I should be getting, procalcitonin or letting that dictate my treatment time. Okay, make sense? All right. So the last thing then is steroids. Is there a role for empiric steroids in the setting of community-acquired pneumonia? And there's been multiple meta-analyses looking at this. Some showed some benefit, some showed didn't. The recent guidelines said, we don't really see a benefit of steroids in the addition of antibiotics for pneumonia, whether it's severe or non-severe, unless the patient has adrenal insufficiency along with it, or refractory septic shock. So I'm not going to be adding steroids, to ceftriaxone and azithromycin, right? Okay. The last thing I'll say is, when you guys present these cases to your senior residents, to your attending physicians, I really want to challenge you to be as specific as possible. Okay, and the reason why is, and not just with pneumonia, but with anything. If you're saying this patient has anemia, I want you to tell me what type of anemia that is. Is it, normocytic, normochromic, is it microcytic, something like that, right? And once you get your iron studies back, I want to know if it's iron deficiency or anemia of chronic disease, because that really, in my mind, in an attending's mind, it really says, well, do we have this patient on the right antibiotic course, right? It's CAP, but is it severe or is it non-severe? Did we get the blood cultures right? Did we get the sputum cultures right? So challenge yourself every time to go through your checklist, just like you look at an EKG and you go through the rate, rhythm, axis, hypertrophy, is there ischemia? You want to be doing the same thing with every single problem representation. Severe, community-acquired pneumonia, no risk factors for MRSA, no risk factors for Pseudomonas. We're going to get blood cultures and sputum because it's severe, et cetera, right? And doing that will help you learn the material faster as well, okay? So I hope this was really beneficial to you. Keep working on your antibiotics. I know it's a really tough subject. We'll hit on this more in future videos, okay? All right, thanks guys.